When it comes to caring for your patients, every detail matters. Knowing the numbers, trusting the diagnostic process, deciding on the right treatment when it matters most. Learn more at atrubihcp.com and see if Attruby is the right treatment for your patients. Please see full prescribing information for Attruby at attruby.com/PI. Brought to you by BridgeBio.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Welcome to this episode on the evaluation of non-obstructive coronary artery disease. My name is Apoorva Gangavelli, and I'm the Chief Fellow of House Einthoven of the CardioNerds Academy, which has put together this episode today in conjunction with an upcoming review article to be published in US Cardiology Review. Co-hosting with me today from House Einthoven is Dr. Rebecca Garber. Rebecca was born and raised in Atlanta, Georgia, attended medical school at the Lewis Katz School of Medicine at Temple University in Philadelphia, and completed internal medicine residency at the University of Illinois in Chicago. After residency, she then served as a medical education and research chief resident. Rebecca is now a first-year cardiology fellow at The Ohio State University. She's passionate about medical education and created the website When the Beat Drops to serve as a trainee's guide to the CICU. Welcome to the podcast, Rebecca.
Thank you so much. I really appreciate it. I'm excited to be here. And with that, I'll introduce Tina Reddy, who grew up in Corpus Christi, Texas. She earned her MD, MPH at Tulane University School of Medicine in New Orleans, Louisiana. She is currently an internal medicine resident at Johns Hopkins. She has a strong interest in cardiac critical care, preventative medicine, digital health, and addressing health disparities through community clinical partnerships. Welcome, Tina.
Thank you, Rebecca. I'm excited to be here with you all and discuss the nuances of non-obstructive coronary artery disease. When patients present with angina, the initial concern is to rule out obstructive coronary artery disease. Up until recently, it was easy to divide patients into two categories: those who had obstruction on angiography and those who did not. We treated those who had obstruction with stents and medical therapy, while everyone else was given reassurance. This paradigm changed with the advent of cardiovascular imaging that showed evidence of ischemia despite quote-unquote clean or non-obstructive angiograms.
It is crucial to note that the absence of obstruction does not rule out ischemia or infarction. Unfortunately, many patients who do not have obvious signs of coronary artery disease remain underdiagnosed and treated as lack of obstruction on angiography and can mask underlying disease. Given the negative outcomes and the underdiagnosis, providers must be educated about these pathologies and have a high index of suspicion when patients present with chest pain and no coronary artery obstruction. Today, we are going to learn more about myocardial infarction with no obstruction coronary arteries, MINOCA, ischemia with no obstructive coronary arteries, INOCA, and angio with no obstructive coronary arteries, ANOCA, so that we can learn how to better diagnose and treat our patients.
Today, we are thrilled to have Dr. Claire Raphael join us in our discussion. Dr. Raphael is an interventional cardiologist certified in both the United States and United Kingdom. She trained at Imperial College London and the Royal Brompton Hospital, with additional cardiology training at Mayo Clinic. Dr. Raphael completed a PhD in intracoronary physiology in 2016 and has published extensively in leading cardiology journals, including JACC, Circulation, and the European Heart Journal. After serving as an attending interventional cardiologist at Cleveland Clinic, she returned to Mayo Clinic in 2022 as an assistant professor and senior associate consultant. Her clinical interests include coronary intervention, myocardial infarction, including type 2 MI and MINOCA, coronary physiology, coronary microvascular dysfunction, and coronary spasm. Dr. Raphael, thank you for joining us today.
Thank you so much for the invitation. I've been a big fan of CardioNerds since I worked with Amit Goyal when I was working at Cleveland Clinic, so it's a real honor to be here.
Before we jump into specific cases, Dr. Raphael, can you tell us a little bit about what made you interested in the world of microvascular disease?
So a lot of it's been, as you said, the past 10 years and over my lifetime as a cardiologist. So when I was a fellow, it was very much, as you said, there's obstructive disease. And if you don't have obstructive disease, you don't have heart problems. And it's been great just realizing how much undiagnosed disease there is. So I now run a clinic for specifically patients with suspected microvascular disease. And the common story we get is someone that's been ignored over and over again. And it's usually a woman. They've usually come in with recurrent chest pain. And when you finally are able to give them a diagnosis, it's incredibly satisfying. And we know that it really helps their quality of life. So it's a really great area to be working in.
You're doing such incredible work, and we're excited to learn more today. So with that, let's start with our first case. We have Miss INOCA, who is a 56-year-old female who presents to the ED with chest pain. She has a history of diabetes, hypertension, and tobacco use. The patient notes that she was working in her yard when she suddenly started having chest pain. She endorses that she had this chest pain before, but it has been getting progressively worse over the past few weeks. On arrival to the ED, her blood pressure is 150/70, heart rate's in the 80s, and she's saturating well in room air. Labs are overall unremarkable, and EKG just shows nonspecific T-wave inversions. Given concern for unstable angina, she is started on heparin and aspirin loaded. The patient undergoes cardiac angiography during her hospitalization and is found to have luminal irregularities throughout her LAD, left circumflex, and RCA, but no significant obstruction. Dr. Raphael, given the patient's history and risk factors, what specific pathologies would you consider when trying to diagnose the etiology of the patient's chest pain?
So this is a really common story. This is a patient with some risk factors for obstructive coronary artery disease. So that's going to be the first thing that you're going to rule out. And the important thing is that the story doesn't end there. So we know she hasn't got obstructive disease. And if you then look at the AHA and the ACC guidelines for MINOCA, the next thing you want to do is just make sure you haven't missed anything. So it's important to really carefully look at the angiogram. She's a woman. She's got risk factors for SCAD. That's 8-to-1 female compared to male. It could be microvascular disease. It could be coronary spasm. It sounds like it's an exertional pain, which would fit more with microvascular disease rather than coronary spasm. And then you've also got to think about your MI mimics. So could this be Takasubos or a new diagnosis of cardiomyopathy? So important to get an echo and see what the heart's like structurally.
Thank you for nicely outlining the spectrum of non-obstructive coronary syndromes and how they have overlapping features but are distinct entities. Despite the reassuring angiogram, Ms. INOCA is still very concerned about her chest pain, as has been getting progressively worse over the past few weeks and occurs anytime she overly exerts herself. She was training for a 5K but had to drop out because she can't run more than 10 minutes before having to stop due to chest pain. In this case, given the lack of acute myocardial infarction, INOCA seems likely. In which patient populations should we have a higher index of suspicion? And if not diagnosed appropriately, how can this negatively affect our patients?
INOCA is predominantly in women, so it's usually 60 to 70% women, and one of the few cardiac syndromes that are predominantly in women rather than men. There's a lot of common traditional cardiovascular risk factors with obstructive disease. So the fact that she's hypertensive and diabetic, that's risk factors for both obstructive and non-obstructive coronary artery disease. Other specific questions you might ask in the suspected INOCA population is a history of Raynaud's or migraines. We know that both of those have historically been associated with microvascular disease and with coronary spasm. But this is a really common pathology. So around half of patients with a so-called normal angiogram, so non-obstructive disease, with a positive stress test, do end up having INOCA.
Going into the causes of INOCA, can you explain the pathophysiology behind these etiologies?
That's still something we're learning a lot about. And one interesting thing about INOCA is it is a big range of conditions. So microvascular disease is going to be the main cause of INOCA. But even within microvascular disease, there's different endotypes of microvascular disease. So in centers that do microvascular testing, we like to stratify patients by endotype, by either endothelium independent or dependent. So that's whether you get abnormalities when you give adenosine during provocation testing or acetylcholine. And then also whether it's structural or functional disease. So that depends what the microvascular resistance is during provocation testing.
I love this discussion because it really shows the nuance to this non-obstructive coronary artery disease. And it's really not just, does someone have coronary artery disease or not? There's so much more that goes into it. So thank you for explaining that. Each year, it is estimated that about 11 million adults present to the ED with chest pain, making it the second most common reason patients come to the hospital. With the advent of high-sensitivity troponin, we can easily detect cardiac injury and ischemia. In a case like MINOCA, where the troponin and EKG are negative, how do we know which patients warrant additional workup?
So it's tricky, and I don't think we're well risk stratified yet. I think that's very much an area of active research. She has a negative troponin, which is a good prognostic factor. We know that patients with a positive troponin are much more likely to have recurrent events. But she's also had recurrent chest pain, and we know that patients with INOCA often end up coming back to the ER multiple times before they really get a diagnosis. And it's not a benign condition. We know there's 1.4-fold increased risk of cardiovascular adverse events. So heart failure with preserved ejection fraction, myocardial infarction, and recurrent hospitalization for cardiac chest pain. And it's hugely associated with a poor quality of life due to all of that chest pain and all of that natural anxiety that comes of wondering every time you get chest pain, am I having a heart attack?
Now that we better understand ANOCA and the different pathophysiologies behind the disease, are there any additional tests you would like to order to help discover the etiology of the patient's angina? If MINOCA presented to you in clinic instead of the hospital, would this change the workup?
So the advantage of being in hospital is you've probably got a little bit more availability of tests. So she's had her angiogram, which is great. And the next thing you want to do is look at the heart structure. So an echocardiogram is really helpful. But the other really useful test is cardiovascular magnetic resonance. And this gives us a huge amount of information, as well as seeing ventricular structure and function. We can also look for any myocardial fibrosis or scarring that might suggest previous events, look at any previous cardiomyopathy, and it's also a really sensitive measure of any MI mimics like Takotsubo's or myocarditis.
Dr. Raphael, how do you know which test to order first and when to proceed on ordering the next test? And maybe a little bit about limitation of these tests as well.
So again, it's tricky. The MRI in general, if you can, it's good to get it early because if there's acute pathology like myocarditis or Takotsubo's, you'll be more likely to pick up the acute abnormality. So you get increased edema on stir imaging on your CMR, and you may not see that if you did the MRI 2 or 3 weeks later. With the invasive testing, it isn't something we generally do as an inpatient. We usually let the patient go home, probably try a couple of different empiric therapies before we go on to do the invasive provocation testing. So at least we just get a feel of whether the chest pain settles down by itself, or is this going to be a chronic cardiac condition?
And before discharging MINOCA, are there any medications you would start on the patient? And how do you risk stratify these patients?
So medications, if I think this is ANOCA, one thing I would usually do is give them some sublingual nitro and ask them if they're able to take the nitro if they do get chest pain again, because firstly, it's therapeutic, but secondly, that's a very useful diagnostic test. So if they've got chest pain that rapidly responds to nitro, then that really does increase your likelihood of being either vasospasm or endothelium-dependent microvascular disease. So that's a useful diagnostic test. In terms of starting other medications, we talked about her being hypertensive, so I'd like to control her blood pressure, and favoring agents like ACE inhibitors or beta blockers, which are both shown to be first-line agents in microvascular disease. The next thing I'd want to know is what her lipid profile was like, and she's diabetic and hypertensive, so she probably does have an LDL above 100, and usually I'd start a low dose of a statin. So we don't have good, clear guidelines for LDL within microvascular disease, but I usually aim for less than 70. And we know that endothelial function will improve significantly if you start a statin.
So now, a month later, you see Miss MINOCA again in clinic. She has more peace of mind when it comes to her chest discomfort. However, she's still frustrated as she continues to have occasional chest pain and is unable to run her 5K. In this type of case, what do you do about refractory angina?
So this can be really tricky, and it's always women, they're usually pretty fit and healthy, they usually run a pretty low blood pressure, so it's a challenge to do medications. So first line, we'll try beta blockers or ACE inhibitors. If you haven't got the blood pressure for them, Renexa is really good, and there's a few small trials in microvascular disease showing improvement with Renexa, statins and so on. Unfortunately, many of the INOCA patients don't end up being completely chest pain free. So then we look at more novel agents like the coronary sinus reducer. And that's really given a lot of hope to a number of our patients that have had ongoing refractory angina despite all of our medical therapy.
How do you approach counseling on preventative strategies for ANOCA beyond pharmacologic therapy?
So a lot of it's reassurance. We know that a lot of patients with microvascular disease are afraid to exercise, and their greatest fear is that they're going to have a massive heart attack as a result of their cardiac condition. So a lot of it is reassuring them that this is a condition that it will cause recurrent chest pain. It does have prognostic implications, but it doesn't tend to cause a huge heart attack, and it is safe to exercise. So a lot of reassurance, referring patients to cardiac rehab so they've got that supervision and peace of mind of having an expert in the room while they're beginning to exercise and build up their tolerance is really, really helpful.
I appreciate that messaging and highlighting kind of lifestyle changes that patients can make as well. This has been an enlightening discussion so far that really helps to highlight the importance of microvascular disease. Dr. Raphael, in your opinion, what's on the horizon for microvascular disease, especially in the age of artificial intelligence?
So I think one thing we're all moving towards is specific endotyping of types of microvascular disease, recognizing it is a heterogeneous condition and probably first-line therapies are going to be guided by the hemodynamics that we see during provocation testing. And the second thing is just trying agents that are specific for microvascular disease. So most of the therapies that we use are therapies that we've derived from treatment of obstructive coronary artery disease. And things like the coronary sinus reducer really do have probably quite a unique role that are well suited to microvascular disease.
I think that rounds out our case, and we appreciate all of your discussion, all your points. In typical CardioNerds fashion, Dr. Raphael, before we end, can you tell us about what makes your heart flutter about cardiology?
So this hasn't changed since I decided to become an interventionalist when I was a fellow. It's your big, juicy STEMI. There's nothing like it. It's just very satisfying. I love getting the artery open and the patient going from having chest pain and being really unwell to just feeling better again. Even at 2 a.m., there's nothing like it.
To summarize what we've learned today, non-obstructive coronary artery disease is more common than many realize, especially in women and especially in people with risk factors like diabetes or hypertension. Unlike traditional blockages that we see on angiograms, conditions like INOCA, ANOCA, and MINOCA cause real ischemia and chest pain even when the arteries look clean. This can happen because of small vessel or microvascular dysfunction, spasms in the coronary arteries, or subtle plaque that doesn't show up as a major obstruction. Diagnosing these conditions often requires looking beyond standard tests, using imaging or specialized invasive studies to assess blood flow and vessel function. Treatment focuses on lowering cardiovascular risk with medications like aspirin, statin, ACE inhibitors, or ARBs, and managing symptoms with drugs such as beta blockers or calcium channel blockers. The key takeaway is that a normal angiogram doesn't mean that nothing is wrong. These patients deserve a thoughtful, evidence-based approach to get relief and protect their heart health. Dr. Raphael, thank you so much for taking the time to teach CardioNerds. A special thank you to Rebecca for planning this discussion and to Tina for leading the matching review paper. Keep an eye out on the US Cardiology review.
Great. Thank you, everyone, so much. It's been really good fun, and thank you for the invitation.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeCom Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.